All right, good evening, everybody, and welcome to this evening's symposium sponsored by Concept Medical. It's a privilege to be with you all today. My name is Suhas Hardas from Columbia University in New York City, and I'm delighted to be joined by a number of illustrious colleagues from around the globe. We have an exciting program focusing on drug-coated balloon therapy with the Sirolimus Coated MagicTouch Balloon. We had a superb late-breaking clinical trial presentation earlier today, which we'll review, and we'll subsume everything from the coronaries to the distal aspects of the circulation in the legs. So without further ado, I know some of our faculty have flights to catch to get home for the holidays, and so I'm going to start with Dr. Suhas Hardas from Pune. He's going to start with a presentation on when do I not use the stent, situations for DCB consideration and long-term follow-up.
Good evening, ladies and gentlemen. I'm going to be showing cases where I have used MagicTouch, the Sirolimus Coated Balloon, and there are no financial disclosures except that I would be reached to the airport in time by whatever means. Situations, ambiguous landing zones, thrombus obscuring the landing zones, TME3 flow in the infarct-related artery after a successful thrombectomy. We keep talking about thrombectomy as not class 1A indication, but a lot of us keep using this device. And there is no clear lesion, a young individual without risk and purely thrombotic lesion, less than 45, side branch of a main vessel which is provisionally stented, unfavorable angle of a side branch for two-stent strategy in a bifurcation, distal LAD lesions for any risk individuals because you want to keep this area free of metal, free of scaffolds for subsequent use for the bypass surgeons. Small vessels and long lesions in small vessels, these are the typical indications now, and difficult to track the stent into the lesion and very, very desperate situations. And why do I not use? Because of obvious reasons we all know. Restenosis, even at 10 years, is almost 10%. Aneurysm, stent thrombosis, loss of vasomotion, which is one of the most important factors according to me. Accelerated atherosclerosis in other vessels, and how that happens, we shall see that in a second. Delayed TLRs and TVFs, and need for a long-term antiplatelet, and the risk of bleeding, which is a dynamic phenomenon. Now, this is case one. A known patient of polycythemia vera came with a hemoglobin of 24 gram% and had an end-STEMI of the anterior wall. Obviously, the problem here was purely thrombotic, and we decided to conserve this gentleman. Second situation where you have a trifurcating left main and an ostial lesion of the ramus branch. If you want to place a stent here, you will probably jeopardize either the LAD or the circumflex ostium. And therefore, we decided to do the angiosculpt dilatation of the ostium of the ramus and then apply the DCB, and the results were holding pretty well even after 6 months. Case 3, angiography in an anterior wall infarct showed a totally occluded LAD. Thrombus extraction was done, and my fellow decided to put a drug-coated balloon. I don't know whether that was correct, but he did it, and the check angiogram few months later showed that the lesion was holding extremely well. Case number 4, ISR due to a neointimal hyperplasia. Angioplasty to the LAD was done twice before, so already there was a lot of metal in the proximal part of the LAD, and now there was inducible ischemia in the LAD on myocardial perfusion imaging. And the CAG revealed that moderate severity in stent restenosis, and plan was to do a IVUS-guided PCI. There was continuous melon seeding, so angiosculpt dilatation was done, and post-DCB, this was the result. This gentleman has had ischemia testing recently after a couple of years and is holding all pretty well. Important side branches, case number 5, a 74-year-old man presented with unstable angina. So the side branch dilated with a drug-coated balloon, and a proximal stent is placed in the LAD. A very young fellow presented with total occlusion of the left main, and we have seen a lot of these during COVID times. Obviously, the problem here was purely thrombotic. He came with cardiogenic shock, required CPR for a long time. The angiography was done, which showed total occlusion. Multiple attempts of thrombus suction were done. Multiple attempts to dilate the thrombus and aspirate the thrombus were done. But after a long struggle of 1.5 to 2 hours to achieve something, this is what we achieved. At the end of the case, we decided that we will not stent this. We will leave it like this on GP2V3 receptor antagonist, low molecular weight heparin and DAPT, because the bleeding risk in this young fellow was very less. Pre-discharge angiogram showed that the circumflex had essentially cleared of thrombus. There was residual thrombus in the LAD, which was treated with DOACs. And 6 weeks later, you can see that there is a clearance of the thrombus from LAD as well. Small vessel, distal disease, you can see that the proximal lesion was stented, and the distal lesion, after balloon dilation, there was a reduction in the flow. However, this man had a CT angiography which revealed that the side branch, that is the PDA, is widely patent. Case number 8, a diffuse distal LAD disease. This is one of the commonest indication in my practice. There is a little bubblogram in the left panel, unfortunately. You can see that there is a long drug-coated balloon dilatation done distally, and there is a stent placed focally in the proximal lesion. The result is holding very well. Case number 9, extensive ASMI, critical LAD disease, proximal LAD stent, and once again, distal drug-coated balloon dilatation done. Ischemia testing has been done in this gentleman recently, and the result is holding pretty well. Case number 10, a young fellow once again came with infero-posterior wall MI, with a lesion in the LAD as well, and a critical lesion at the bifurcation of the circumflex and OM. That was dealt with the routine that we have in our hospital. So 2-stent strategy here. And then you can see that there is another young fellow presenting with unstable angina. He is homozygous for familial hypercholesterolemia and has, unfortunately, triple vessel disease, a bifurcational OM circumflex, a bifurcational LAD diagonal proximal, a distal LAD lesion, and you can see that there is a retrograde filling of the right coronary artery. So circumflex was dealt as we could. The LAD diagonal bifurcational strategy, 2 stents were used, and distally the drug-coated balloon dilatation was done. 1 month back, he has had a CT coronary angiogram, which is pristine normal. The right coronary artery was totally occluded with an aneurysm. This was dealt with by a covered stent. There is some disease in the distal part of the RCA that was left for medical management. This is an interesting case. A gentleman who is a very ardent athlete, runs marathons, after a long run, had a syncopal attack and was taken to the hospital, where he showed a lot of STD changes and was subjected to angiogram, which showed critical lesion in the proximal part of the LAD and a diffuse long segment lesion in the distal part of the LAD. The proximal part was stented. 6 months later, the result is holding extremely well. 8 years later, once again, the result is holding fairly well. And once again, 2 months back, that is almost after 10 years and 2 months, he has had a coronary angiogram, which I do not have here, and shows that the results are holding extremely well. Intact endothelium-dependent vasomotion is an important prerequisite of vascular health. Vasomotion is also an important mechanism for controlling microvascular perfusion. Vasomotion refers to rhythmic oscillation in arteriolar diameter over time. Vasomotion contributes to autoregulation, which can be extremely crucial in athletes. Nitric oxide released from intact endothelium is a trophic substance, and there is nitric oxide mediated endothelium-dependent vasodilatation. All these mechanisms help to ward off the pathogenetic mechanisms involved in atherogenesis. So all the therapies like DCB and BVS, which will treat critical and ischemia-producing lesions or stenosis, yet will keep the vasomotion intact, will definitely find a permanent place in future therapies. Now, why I have been talking about vasomotion, vasomotion, vasomotion all the time, I think everything must revolve around vasomotion, and there is a reason why I think subsequent speakers are going to deal with what is the difference between a sirolimus coated balloon versus a paclitaxel coated balloon. Conclusions: DCB normalizes the shear stress, restores normal vessel curvature, reduced risk of late polymer reaction, avoids delayed acquired malapposition. In fact, loss of lumen is a rule in DES. But if there is a positive remodeling, it forms a very good stage for delayed acquired malapposition and a possibility of delayed or very late stent thrombosis. It avoids late strut fractures, reduces neoatherosclerosis, unjailing of the side branches we have seen several times. Late bypass surgery options are always open, allows treatment of ISR without necessitating permanent additional metal layer, and facilitates non-invasive imaging follow-up without artifacts. And it keeps the vasomotion intact. Thank you very much.
That was a phenomenal series of cases with a variety of different indications, but yet great results all around. And you know, and honestly, for us in the United States, we're a little hamstrung by the cost implications. Quick show of hands, because we have a mixed audience at TCT. How many of you have access to the MagicTouch balloon presently? So just a small number. And how many of you are typically using DCB for de novo disease? Some as well. So there's so much to learn in this space, and I think that we need to start with some of the basics in terms of what the actual device is, and for that, no one better than Aloke Finn to take us through exactly what this device is.
Ajay, thank you so much. Let me see if I can get this. One second. There we go, there we go. Okay, we got it, we're good. I think I'm okay. Yeah, I got it, I'm good. Let me, yeah, we're good. All right, great. Thank you so much, and thanks to Concept for inviting me to give this talk. I felt like the last lecture maybe foreshadowed some of the things I'm going to discuss, strangely enough, but it's good that we synergize into everything. I'm going to talk a little bit more about the basics of drug delivery and how drug-coated balloons work. Rather than just the clinical message, I want to talk a little bit more about understanding the basic methodologies. Here are my disclosures. As you all know, DCBs for peripheral or coronary artery disease and peripheral artery disease really are mainly composed of paclitaxel coated balloons, as you all are familiar with, probably because they're a little bit easier to make and they're a little bit simpler in terms of how they work, and I'll explain some of that in the lecture. There really are two leaders in this field for sirolimus coated balloons. There's the solution made from Med Alliance, now owned by Cordis, and there's the Concept medical balloon. Both of these have testament to the safety, have gotten approval for IDE studies. The solution, I think, is just in the middle of its ISR study. Same with Concept Medical. But these are really the two leaders in terms of sirolimus coated balloons, and I think they represent the forefront in this technology. What are the differences between a DES and a DCB? It's important to understand the basics of this thing, just so you understand exactly. We're used to DES, we all know DES, and DES in some ways have been perfected. DES really rely on a polymer and a metallic scaffold, which is attached to that polymer to deliver drug. And they're very successful at delivering drug in the tissue, which we like to see in the artery wall at detectable therapeutic levels for at least 60 to 90 days. And they really work very effectively. I don't think anyone in this room would deny a DES is a very effective solution for de novo disease and to some extent for ISR. DCBs are a more complicated thing to make, because really there's no scaffold. You have to rely on the transfer of the drug in that 1 minute or whatever number of minutes you're using for inflation time, and that has to transfer to the wall and stay there. And you need a mechanism for the drug to retain there. You need to make it retain there for time in order to cause an anti-restenotic benefit. The drug can't just simply disappear. And so, for the paclitaxel, it's crystalline form. For sirolimus, it's really a carrier, and I'll discuss this in a little while. So excipients and carriers are really important in DCBs. And, as I said, the drug transfer must occur in a short period of time, and the drug release and permanence must be sustained over a minimum, I'd say, of 60 days. The success of a DCB is really dependent on multiple things. It's dependent on the excipient, the drug, the balloon, and the application site. There are many variables involved. It's more complex. For paclitaxel DCBs, paclitaxel has been the drug of choice, but the rate of solubilization and bioavailability is determined by the different excipients as well as the paclitaxel composition. And it's important to understand that paclitaxel is a complex organic compound, and really it occurs in multiple forms. For the DCB, really what's dominated the field is the crystalline form of paclitaxel. Now, why is that? If you compare the amorphous and the crystalline, amorphous is solubilized much more easily. Think about crystals in your crystal glass. That's kind of what we're talking about here. The crystalline form really has advantages in terms of things I want to point out. The drug transfer is probably equivalent to the amorphous form. The drug retention time is simply superior. What happens is those crystals deposit in the wall and they elute drug over time. So they will slowly elute that drug, but they'll stay in crystalline form. The biological effectiveness is greater, but the drawbacks are also greater. If you think about particulate matter generated by shattering your crystal, if you drop your crystal on the floor, it's going to shatter 1,000 pieces. You're not going to be able to put that glass back together. If you think about vascular toxicity, the same is true for paclitaxel. It's a much greater level of vascular toxicity than sirolimus. And you can see this is proven here by this study done by Granada, where he used crystalline paclitaxel versus amorphous. And what he just shows simply, this is the PK, this is the drug in the wall. What he shows in that black bar at the top is that the drug in the wall is just simply greater and extends longer with the crystalline form of paclitaxel than the amorphous form. This is why we use crystalline paclitaxel in balloons. And I'm not here to deny to you that paclitaxel is an effective anti-restenotic agent. I think this is one example. Impact SFA, a well-known paclitaxel balloon, very successful in terms of reducing TLR rates in the SFA, and other studies have shown this in other areas. But the problem is, of course, we don't have very good drug transfer with drug-coated balloons overall. If you think about it, the amount of drug that actually gets to the wall and stays there is about 10 to 15%. It's nowhere near the full loaded dose. And where does the other parts of it go? Some of it's lost in the body. Some of it retains on the balloon. So you've got very inefficient transfer that occurs with this type of balloon. And it's obviously shown here, as I said, if you blow up a balloon, don't have to take what I say. Take one of these balloons, blow it up on the bench top, and see what happens. You're going to see all little flakes everywhere around that balloon. And that is really the crystalline material that comes off that balloon. Think about what happens in the artery wall. It's impossible those flakes all go to the arterial surface. And if you look at even the most advanced drug-coated paclitaxel balloons, and some that are gotten approval for IDE trials here, I'm showing you one from Medtronic, you can see that what we see downstream of treated beds, in the downstream zone, if you treat the LAD, for instance, and you look at the downstream myocardium to the LAD, you see all sorts of little areas of embolic debris. And those embolic debris are really seen as collections of inflammatory cells surrounded by fibrin, which can sometimes plug up small arterioles and cause necrosis if it's really a bad embolic event. And you can see that in some of the cases by polarized light. Now, this has been shown, you could say, well, this is just an animal phenomenon. This has been shown in clinical studies. It's well known that when you do paclitaxel-coated balloons, for instance, in the SFA, sometimes the flow velocity decreases. It doesn't decrease after a POBA, but it will decrease sometimes after a paclitaxel-coated balloon. And that just shows you evidence that what you're seeing there is you're seeing microvasculature start to be impaired by impaired flow velocity. And you say, well, this doesn't really matter. It's a small little arterioles in the bed. It doesn't make a difference. Well, if you think about it, why have paclitaxel-coated balloons not succeeded below the knee? One of the reasons is because people who are getting below-the-knee angioplasty are fairly sick. The flow is very low in a lot of these people. And when you get distal emboli, you impair the flow further, and you get worse wound healing, you get lower amputation-free rates. So these are issues that really are important in terms of clinically translating these findings. So sirolimus coating design requirements, what do we need? Well, we need to improve the tissue absorption, and it's limited because sirolimus degradation diffusion occurs rapidly. And so you've got to encapsulate the sirolimus in something that holds it there and elutes over time. The free sirolimus in the tissue actually deactivates very quickly. If you just coat a balloon with sirolimus and you blow it up, it won't work. You won't get any anti-restenotic benefit. The drug will be gone. And you also want to minimize distal embolization. So the goals are increase drug uptake, extend tissue retention, that is, have the sirolimus in the wall for at least 60 to 90 days, and protect wash-off. And for the MagicTouch, of course, the secret here is this phospholipid carrier, which is in the single micron digit range in terms of its size. And that really encapsulates sirolimus and helps with the transfer. The positively charged phospholipid helps with the transfer to the vessel wall, and then it houses that over time where it elutes and keeps drug going over time to be successful. And I think I'm going to show you just an example in the animal model of how simple study, where we randomized animals to POBA, this is in the coronary intervention, a MagicTouch SCB, a solution SCB, or a agent, and that PTX DCB is agent. We then followed these animals up at 28 days and looked at the histology as well as the downstream embolic impacts. And you can see what we do for the coronary arteries, we do histologic analysis. We look for drug effect by these different parameters, and we score them according to a scoring system. And we basically use the three most injured sections out of 5 and score those sections. And then for the distal myocardium, we have a whole scheme where we collect different parts of the heart downstream of different arteries to look at distal embolization and whether there's evidence of distal embolization. This is the image of the porcine coronary arteries after different treatments, just an example image. We're not looking at anti-restenotic benefit. We can't show that in an animal model. But we can look at the effect of the drugs on the artery wall. And what I want to point out to you is the distinctive effect of paclitaxel versus the POBA, MagicTouch, and solution. You see there in those red arrows that the media is itself very impaired by the paclitaxel. The media starts to die, and it starts to have some effect on medial smooth muscle cells. And this is an important impact of paclitaxel. And if you look at the histomorphometry, there are really no differences in terms of the vessel size, the lumen area, the stenosis. We really don't see those in an animal model, to be transparent. But what we do see is we see that smooth muscle cell loss is almost distinctive to paclitaxel. Paclitaxel is the only balloon, not the sirolimus balloons, that have a significant loss of smooth muscle cells, and that's shown here in the scoring we did. This is an important thing to understand. And in terms of histological downstream analysis, what are the embolic effects of these different balloons? It's important. I told you the transfer was inefficient. What happens downstream? Well, we see downstream that myocyte necrosis, that is death of myocardium, or scarring myocytes actually, and scarring really are exclusive to the paclitaxel coated balloon. The sirolimus coated balloons don't cause any downstream myocyte necrosis or scarring, and a POBA, just a regular balloon without a drug, doesn't cause that either. And when you look at embolic debris, so I separated it into necrosis, scarring, and emboli. There are emboli with every drug-coated balloon. I'm going to be quite honest with you, but they're most with agent, and they're less with MagicTouch, and the least with POBA. And this is a very important finding in terms of the safety of the product. And you can see here, as to be transparent, the histology, you look down at the PCB, which is the agent, you can see areas of scarring. Look at these areas, and the myocytes are gone in these areas, right? These are replacement fibrosis by 28 days. So you've scarred the myocardium, you've killed it, and you've got replacement, a small MI in some ways. And then, or microscopic scarring is actually what we call this. And you can see there are other areas where we see evidence of embolic debris. There may not be myocyte necrosis, but there are certainly large collections of inflammatory cells surrounded by fibrin, where you know this was a paclitaxel emboli. Now, for the MagicTouch in solution, I said the myocytes and the myocardium looked intact, but you do see small embolic debris. Their meaning is not clear because they didn't cause an infarct. So it's important to understand that. So conclusion, excipients and transfer carrier technologies facilitate drug transfer and release to the vessel wall and are necessary for DCB success. However, each DCB has distinctive components which need to be carefully evaluated for their safety and their efficacy. This is part of what the FDA does, but part of what we do. Paclitaxel DCBs have proven efficacy. I don't want to argue with you about that. I think they do work, but their safety remains an issue. Sirolimus DCBs appear to be safer from an embolic standpoint, and their efficacy can only be shown really by clinical studies. And I think Ulf is going to present the SIRONA trial. We'll get a good idea of what it does in humans. This area continues to evolve, and we'll see improvements in DCB technologies as the technology matures. So thank you for your attention.
Great talk, Alok. We have some interesting and hot questions for you at the end. But before that, let's move on with the program. And it's a pleasure to invite my good friend Sandeep from Great Britain, who has huge experience with DCB, especially with MagicTouch. Very tough and complex cases that I'm sure you're going to be mesmerized with his slides.
Thank you so much for the hype. Okay, so the problem is when you give such a hype, it's very difficult to keep the expectation. I'll try my best. So thank you all. It's a great honor to be part of this symposium, and thanks to the Concept Medical for this opportunity. And so my job is to show some of the technical aspects of DCB angioplasty, tips and tricks when using a DCB. I assume you all are convinced with the DCB works in coronary arteries, and hence you're here. So I will now focus more on the lesion preparation, which is very important, followed by how to confirm an optimal lesion preparation and how to assess post-DCB outcome. Because I feel that the DCB angioplasty differs from a conventional angioplasty on various aspects. So let's start with the lesion preparation. So I always say that you have to pre-dilate the lesion because DCB is just a drug delivery balloon. You have to prepare the lesion before you deliver the drug, because it's like painting the wall. When you want to paint a wall, the last bit of the procedure is the painting. So that's the drug-coated balloon. But before that, you have to fill all the gaps and all the stuff. Otherwise, you'll have a bad job like this, and you blame the technology. So for me, I consider DCB, but I only make that final decision after the lesion preparation, because lesion preparation is the key, and that tells me whether I can use DCB or not. So I always start with a pre-dilatation with the semi-compliant, non-compliant balloons, because I want to what we call like palpate the lesion. So this is, I take 1:1 balloon to artery ratio, and when I say palpate the lesion, what do I mean by this? I mean two things. One, I want to see whether the balloon is expanding uniformly. Okay, the next aspect, I always look at these. This is a sort of new thing in the last few months I've been doing, looking at the wire position within the balloon. And I'll show you some examples. So let's look at the uniform balloon expansion. When I say uniform balloon expansion, I want to see what happens to the balloon when I inflate. This is just an NC balloon. You could see clearly there is a dog boning in the first slide. And in the second slide, you could see there's a non-uniform expansion. Now I know this is a lesion which is filled with calcium or a fibrosis, and I need to up the game, and hence I'll be using intravascular imaging. So of course I want to use a scoring or a cutting balloon or even rotational atherectomy or IVL, but I have to use an intravascular imaging here. So then I use the intravascular imaging. So for example, this is a case where I inflated the balloon to a high atmosphere. You could see the balloon ruptured and the contrast filling the distal LAD now. And I did an IVUS and I saw a very concentric calcium. So of course, this did not yield with an NC balloon. So I have to up the game. I could use cutting balloon, but here I used IVL. And because I believe in IVL because it's a low pressure inflation. And you could see there's lots of cracks which developed post-IVL, and hence I treated that with a DCB. So next look at the wire position. So what do I mean by that? So for example, this is a mid-LAD lesion. I wanted to use DCB. I took a 30/20 NC balloon. Look at the position of the wire within the balloon. It's very central, which means the balloon is expanded uniformly. And this is post-predilatation. It's almost like a stent-like result. So here, I had no reason to use a stent here because patient was a high bleeding risk patient and an excellent predilatation. So with just an NC balloon, uniform expansion, wire in the central place, ready for DCB. Let's look at this case. This is a case which I did with James Pratt in our center. So you could see there is although the balloon's expanded, you could see the position of the wire. The wire is very eccentric, which means there is a calcium which is pushing the balloon to expand the other way, where there is least resistance. And of course, we used IVL. And when we used the IVL, clearly the wire bias changed. The wire became more central because you cracked the calcium. So what we saw was a wire bias initially, which changed into the central position, which means the calcium was cracked. And I'll show you another example. This was a case we did recently. sort of subtotal occluded LAD. You could see here when a balloon is expanded, although balloon looks expanded, what you see is the position of the wire is very eccentric. So this is not a good expansion. So don't take this as a good lesion or a preparation. So obviously we went with the cutting balloon, and you see here, when we use a cutting balloon, the wire position change becomes more central. Okay, this is very good, especially in a straight arteries like this. You don't need an IVUS to tell there is a calcium or a fibrosis. When you start using lesion preparation, I normally take a longer balloon. So this is very, very important, because if you have a 80 millimeter street and you take a 12 or a 15 millimeter, you'll have to do multiple inflations. Take a 25 or a 30 millimeter balloons, and you can do just two or three inflation, you can treat the lesion. The other thing I tend to do is I tend to leave the balloon longer. So I inflate them for at least 30 seconds, because by doing this...
Inflation, still some ectopics. I'm not
Oh,
sure
sorry,
this
it's
is wire related.
my
maybe
voice,
it's
I didn't
schema
realize.
related rather than anything else, because
I thought someone talking. So essentially what I was saying, this is a live in the box. We were recording a case for a meeting. So we inflated the balloon for 30 seconds. By doing this, what we did was we achieved some kind of ischemic conditioning, so that when we inflate the DCB for longer, patient tolerated better. So the next bit is, this is very important. You could have a uniform expansion, you could have a central wire position, but despite that, you could have a recoil. And this is very, very important. I'll show you an example. This was an ostial occlusion of a PDA, acute MI. So we pre-dilated with an NC balloon. You see the balloon's expanded uniformly, the wire is central, but when we took an angiogram, there was a recoil. Now, are we happy with this POBA result? The answer is yes. If you want to stent, yes, you can, because it's uniformly expanded. The scaffold will take care of it, the metal scaffold. But here we wanted to avoid a stent because there's a massive size mismatch. So we wanted to use DCB. So we wanted to achieve a better pre-dilatation. So we took a scoring balloon, and you could see post-scoring balloon, the recoil is much, much better. So I'll just show you the post-NC balloon and post-scoring balloon. You can see the difference in the pre-dilatation. Now, post-POBA, it's very important we acquire the image till the contrast disappears, because what you're looking is, if you have any dye hang-up, if there's a dye hang-up, then it's a bad news, because very likely you will encounter a flow limiting dissection. For example, here there is like a type A dissection there, but good thing is there is no recoil and there is a good flow in the distal vessel. So I'll show you this case. This is a case we were treating the PDA. We pre-dilated with an NC balloon. Post-NC balloon, you could see there is a linear dissection, especially in the proximal segment. Okay. Now, because the flow is TME3, we accepted this and we used a long MagicTouch DCB here, and we had a very good result. The dissection was still there. Now, if I was doing this case maybe 10 years ago, I would have placed a stent. But here I accepted it because patient came back for a check angiogram 6 months later, and you could see the dissection is completely healed, and more importantly, there is a remodeling of the vessel. And if you compare the two, post-procedure and the POBA, you can appreciate there's a difference in the way the vessel looking. What dissection you don't want. So this was a lady I was treating the circumflex, okay? I pre-dilated with just an NC balloon, and post-pre-dilatation, she had chest pain, ST elevation, and there was a flow compromise, and there was a spiral dissection. Now this you cannot accept. You have to put a stent here. So which is what we did. We put 2 stents, and a patient had a good result. So this is my algorithm. POBA, after 1-to-1 balloon dilatation, I look at the angiogram. If I have a good result with less than 30% recoil, I go for a DCB 1-to-1. If there is a recoil of more than 30%, I then use a scoring or a cutting balloon, and then I use an intravascular imaging to guide me. If I have a good result, I go for DCB. If I have a persistent recoil, go for stent. If there is a dissection, I look at the dissection. Is type A or type B like the one you saw earlier? I'm happy, I'll take DCB. But if it is more than C or more, like where there's a flow limitation, I go for stenting. Stenting is not bad. So finally, DCB has to be 1-to-1 vessel sizing with the balloon and vessel size. Should be delivered within 2 minutes, which is very good for MagicTouch. It delivers extremely well. And you should never inflate beyond a 6 to 7 atmosphere, because you want to just touch the vessel wall with a DCB. And you see here, this is a long DCB we used in the distal RCA. We inflated for almost 1.5 minutes. Patient tolerated well. Yes, there is some ST elevation. Blood pressure is fine. So you can leave for 90 seconds. I've never had any problem, unless you're doing the left main, which we hardly use for DCB. So post DCB, this is very important. Check angiogram, keep the wire in place, maybe do another angiogram 2 or 3 minutes later, but more importantly, avoid repeated injection, especially if there is a non-flow limiting dissection, because you're going to make it into a flow limiting dissection. So again, this is the same algorithm. Post DCB, good result, no dissection, I accept it, I don't do anything more. If there is a recoil, these days what I'm doing is I'm doing a gentle POBA, and I'll show you a case in a minute. And if I get a good result, I'll accept it. But if it is recoiling, I'll put a stent in. But I'll go for a focal stenting, okay? Same with the dissection. Type A, type B, I accept it. But if it is more than that, then I will go for a focal stenting. So the main aim is to minimize the stent length during bailout stenting. And I'll show you a case. So this is a mid-LAD we are treating. Okay, so we used a 2-long DCB MagicTouch and a stent in the proximal segment. And post-procedure, I had this recoil in the mid to distal LAD. Now, my instinct said to me, go and stent it. But then I thought, I don't want to stent that LAD. It was a young patient. So I went with a prolonged POBA. So I left this balloon for 2 minutes. This is just a 2.5 millimeter balloon. And this is post-POBA. I addressed the recoil. And the patient was fine. I gave nitrates. He was fine. And I didn't have to do anything. Then look at this guy. This is a RCA CTO, okay, subtotal occluded. We crossed, okay. This is post-dilatation. We put 2-long MagicTouch, okay. So we had a result like this. And here again, you could see there is a very good result, except that mid-segment there is a dissection. Now, because it was a big RCA, I didn't want to accept this. I put a very short stent, just an 18 millimeter stent, but I still got the benefit of DCB and rest of the whole RCA. The final point is train your eyes not to expect a stent-like result, because we've all been trained in the stent era, and we want to see this very good, stent-like result. You may not get that in DCB. So, for example, this is again a very subtotally occluded LAD, heavily deceased, and obviously we used a 2-long MagicTouch here, and we put a stent in the proximal segment. This is called the hybrid strategy, and we had a final result like this. Now, obviously, if I was doing this 9-10 years ago, I don't accept this. I feel like this doesn't look nice. But I accepted it because I believe in DCB. And 1 year later, patient came for an angiogram. Now, obviously, the problem is the RCA, which is blocked. And you could see the LAD is grown, and it looks much better. And if you compare the, sorry, I did not compare this, but here. Yeah, so here, if you look at the LAD, it looks much bigger. And certainly, those acute result has been resolved. So, in conclusion, always pre-dilate the lesion, because optimal lesion preparation is very important. And watch this thing, wire bias, very, very important, because if you have a wire bias, you don't need an IVUS to say there is a calcium or a fibrotic lesion. Take a longer balloons. It's very, very important, so you don't have to do multiple inflation. Keep the balloon for at least 20-30 seconds longer, because these days, even my fellows have been trained for a quick angioplasty, quick in, quick out, but you leave the balloon longer and use a specialized balloons if needed, especially guided by imaging. And type A and type B dissection and up to 30% recoil is acceptable. Again, train your eyes not to expect a stent-like result. And if you want to go for a stenting, go for a focal bailout stenting rather than stenting the whole of the treated segment, because it may not be needed. And finally, avoid repeated injection post-DCB, because you don't need to. You only need 2 injections to make sure the artery is okay. Thank you so much.
Thanks, Sandeep, so much. We'll have questions at the end. Now I want to invite Dr. Ulf Teichgräber from Vienna. Ulf had the privilege of presenting the SIRONA randomized trial today in the late-breaking clinical trial session. So he's going to give us a little bit more than an update on the randomized trial.
Well, first of all, I have to get to my presentation. Closing it? Okay. Okay. Great, thank you. Okay, yes. Thank you. And actually, in German, we always say, doppelt hält besser, so twice is better. So today, I actually presented the SIRONA trial, the primary endpoint for the first time in the late-breaking clinical trials session. And probably some of you were present, but I think probably some not. Therefore, I think I want to go through this update of the SIRONA trial, which is actually in the peripheral arteries, Sirolimus versus paclitaxel DCB for the SFA disease. And, well, the investigational product, what surprise, it's MagicTouch. But actually, what you want to know is actually how does a control group look like, paclitaxel group, and we aimed to go against the family. The family means those who are available in Europe, which are approved and also had at least 2-year randomized controlled trial data against POBA. So these were eligible to be by the recruiting centers to use within the trial. And you see that this is quite by the discretion or by the choice of the investigators which one they actually choose. We also have others. Others means also combinations and combination of 2 types. And this is how it looks for the control group. So the SIRONA is a randomized controlled trial. We randomized 482 patients in 2 groups. And importantly, we did the randomization after the vessel preparation. So this is very, very important. Not all trials are doing that. Vessel preparation is key to have a good long-term result. And therefore, we requested at least 1 minute, optimally 3 minutes of pre-dilatation of the lesions. So just to let you know, this was the way how we did it. And actually, we are now looking at 1-year data. And this was core lab adjudicated. So the patients received a Doppler measurement afterwards. And this was done, you see, the follow-up rate was quite high with 88% and 85% at all. So let me just briefly go through the patient characteristics. We are looking here at claudicants, and you see they are very well matched, both groups. This is actually because this trial is very well powered. I mean, with 482 patients, this is really good powered. And there you see also the matching of the group is very well. And also we aimed for claudicants, so category 2 and 3. And you see the majority was clearly in this group. So we excluded CLTI patients for this trial. And this is probably very important to compare with other RCTs, what kind of lesion lengths we were facing. And you see we had 8.4 centimeters of length, lesion length. So these are intermediate lengths of for the SFA. So these are typical lesions where you want to address with a strategy leaving nothing behind. So with balloon angioplasty only. And still, and this is something I was a little bit disappointed, you know, you can't really in a RCT control everything. The bailout stent rate was still, even with our strategy of good vessel preparation, still 23 versus 20% in the paclitaxel group. This is comparable with all other RCTs which were performed with paclitaxel against POBA. So this is a rate about 20%. And this was done if there was still flow limiting dissection. Now the study endpoints. So the primary endpoints we decided in our protocol to go for 2 endpoints as primary endpoints. So the primary efficacy endpoint was primary patency assessed by duplex with a PSVR lesser than 2.4 and no TLR at 12 months. We aimed for non-inferiority. And then the second endpoint, just to be on the sure side, we also have to prove, because there are no data yet, that sirolimus against paclitaxel is also as safe. So we aimed also for non-inferiority for a primary safety endpoint. This is a composite of clinical-driven target vessel revascularization, major target limb amputation, and device and procedure-related death. And aim is non-inferiority. Well, I wanted to say, before I show you the primary endpoint, how I actually convinced Concept Medical to do this trial. I mean, this is not a self-understanding that a company is going for an investigator initiative trial. It's a high risk always. You have a new product and you go right away to compete about standard of care. And this was actually a commentary in the eClinical Medicine. This is a subjournal of the Lancet. Paclitaxel in endovascular devices, identikit as a serial killer. And this commentary was related to our meta-analysis. There was a Cassano's analysis and my analysis. And this one, I was not really focusing on safety in my analysis, but I also figured out that there was an all-cause mortality higher risk, and I was more looking at efficacy. Now, this was where I was interested in. I was not really believing in the beginning that there is also risk with paclitaxel. And, but in this meta-analysis, we actually also had seen the same effect, but we were only in our meta-analysis only focusing on drug-coated balloons and no stents. So this was different to Cassano's analysis, and this is what I wanted to show you. Actually, this is from our meta-analysis, and what is the normal rate difference we expect in primary patency at 12 months against paclitaxel against POBA. And you see here, the normal rate is there 70.8% versus in POBA 51.4%. That means a rate difference over all randomized controlled trials which were available at 1 year, it's 24.4% of rate difference. This is what actually we expect against non-coated balloons. So only keep this in mind, because now I show you the primary endpoint for our head-to-head comparison. So sirolimus versus paclitaxel. And this looks this way. So sirolimus has reached here 73.8%, and the paclitaxel family, I've shown you in the beginning, has 75%. And this makes a rate difference of minus 1.2%. So really neglectable. And this is also, we reach the primary endpoint goal with a p-value of 0.022. So we reach the primary endpoint for this point. This is quite so we have really comparable results with sirolimus and paclitaxel technically with this primary endpoint, patency. And now let's look at safety. This is not astonishing. Of course, we have reached this endpoint also with non-inferiority with a p-value of 0.0053, means the overall event rate was 9.4% versus 7.3%. So this was not statistically, this was statistically clearly non-inferior, and so no question, sirolimus is at 12 months as safe as paclitaxel. This is what we expected. No? Otherwise, it would be bad. But these are technical endpoints. This primary endpoint for me always a clinical indicator is the freedom from clinical driven TLR. And this I show here in a Kaplan-Meier estimate. And as you can see, with the freedom from TLR rate was for sirolimus 92.9% versus paclitaxel 95.4%. So a difference of 2.5%, and also this is clearly here you can see with the standard error 1.7% versus 1.4%, also meaning that this trial is very well powered. So we do not have a lot of lack of follow-up, and you can see here the follow-up rate here, which were completing this endpoint were 92.5% and 90.5%. So this is really a strong evidence that both are really comparable in terms of freedom from clinical-driven TLR, which is, I think, really the most important point. Why also to use sirolimus balloons. And this is also just to compare with our meta-analysis against POBA from 2019, where we had all these trials together. You see there are many trials who reported the 12 months freedom from TLR from paclitaxel against POBA. And you see there you have 90.3%. I go back one slide. Now we are a little bit higher, and this is mainly due to the vessel preparation, and which was not so much done before in these other trials. But there you see the difference. It is at least around about nearly 20% if you compare this with POBA. So these two technologies are really comparable, sirolimus and paclitaxel. But also important is the functional outcome. It means walking capacity, which is measured by Rutherford, and we can see that the change from baseline to 12 months for sirolimus was 2.0, and for paclitaxel was also 2.2. So the between group difference was only 0.1. So this was not statistically significant. So both have the same impact on improving walking capacities for our patients. So this is for the patient the outcome which he's interested in. He's not interested in if he has to do a new revascularization. He wants to walk, and this is something you can see that this works with both technologies the same way. And we also looked at the functional outcome for clinical improvement by at least one Rutherford category. And you see for sirolimus, this is 89%, and for paclitaxel, the same, 89%. So these are really equivalent in these terms. So let me just conclude. This first head-to-head comparison of sirolimus DCB with paclitaxel DCB shows comparable results between the study groups. The primary patency of sirolimus DCB was non-inferior to that of paclitaxel. No significant difference between the groups in terms of freedom from clinical-driven target lesion revascularization, and the clinical improvement of sirolimus DCB was similar to that of paclitaxel. So safety of sirolimus DCB was non-inferior to that of paclitaxel. Thank you.
Congratulations for these superb results. And now to conclude, and our last talk for tonight will be Sahil Parikh, my co-chairman, and he's also one of the leaders in the peripheral approach. Sahil, we are all curious to see your input.
And I will go briefly through the data, and then we'll have some time for discussion. This is what you would say TLDR. I would argue that peripheral artery disease is a very important disease entity, and particularly those patients with below-the-knee disease are extremely high rate of amputation and high risk for mortality. And these small vessels are frequently difficult to treat because we have few options to treat both calcific and dissected vessels. And so consequently, the need for scaffolding is frequently needed and often results in restenosis. So having a DCB that is successful in the infrapopliteal circulation is going to be imperative. At present, the only approved technology in the below-knee circulation in the United States is a drug-eluting bioresorbable scaffold. Off-label use of coronary drug-eluting stents have varied responses, and drug-coated balloons with paclitaxel have been largely unsuccessful, and consequently there's no FDA-approved paclitaxel DCB in the United States for the below-knee circulation. You're well aware of the MagicTouch technology, which has been applied in over 4,000 patients in peripheral clinical trials. And the Concept Medical has received FDA IDE approval for both below the knee and SFA disease. You've heard about the SIRONA trial, but there's a number of other outside the United States trials ongoing. Ulf is reading the LIMES trial for below the knee, and there's also data from Eddie Choke in Singapore, and he's leading now the ongoing RCTs, the future BTK and SFA trials, respectively. And we have over 1,000 patients enrolled in Switzerland in the SIRPAD trial, which is both above and below knee circulation. and again, here's more of the ongoing trials. So I'm going to skip the data because I want to get to the discussion. Just suffice it to say that we have parallel U.S. clinical trials. The MAGICAL series of studies for the below-the-knee IDE is currently IDE approved, and many sites have been activated, and we're about to enroll the first patient probably within the next 10 days. The MAGICAL SFA IDE is going to follow closely on the heels, pardon the pun, of the BTK trial, and that trial will closely resemble the design of the SIRONA trial that you just saw. MAGICAL BTK will enroll 368 patients in a one-to-one fashion against POBA, and the MAGICAL SFA trial will enroll 478 patients. So again, very, very similar to that which you just saw in SIRONA. I'm going to skip over all of this stuff because we're going to get to the end and talk about where we're going with these. So I would argue that these trials are going to look a lot like SIRONA, but I think given that we've just seen the SIRONA data, we need to talk in great detail about the implications of that trial. So I'm going to cede some of my time, take the moderator's privilege, and let's get back to discussion, Alex.
Thank you, Sahil. I think that was a strong message, but we have a few minutes for discussion. Let me start with my friend Aloke. Aloke, from the basics, right? So I always say that when we compare sirolimus versus paclitaxel, in terms of mechanistical results, let's say late loss by QCA and lumen gain and lumen at long-term by IVUS, you're always going to see more favorable numeric results for paclitaxel. So forget about this comparison in terms of clinical benefit. And my take is that with paclitaxel, we're going to see more toxic effect, more positive remodeling, and perhaps aneurysm formation. So you think that you have this illusion that paclitaxel will have perhaps better results in terms of late loss, but in fact, the mechanism of action of paclitaxel in terms of more toxic effect to the vessel wall is greater than sirolimus. Is this an assumption? Is this something that I'm dreaming, or this is reality?
I mean, I like your, I agree with you. I think that, you know, the long-term effects of there's no question the paclitaxel has what you say it has. It has more toxic effects, more cytotoxicity, more medial muscle cell loss. The question is, what are the long-term implications of those findings? I think aneurysms can be found in some cases, especially when CTO cases. And are there issues on vasomotion that we discussed before? Is that something that we need to look at, Alex, a little bit more and see whether, you know, because the media, as you know, is smooth muscle cells, and that really controls the dilatation of the vessel. And the muscle cells either relax or they constrict or they maintain a tonic tone. And so that's very important for the way we auto-regulate. And so I think it's very important to try to understand, and I don't think anyone has looked into this. Does paclitaxel impair that auto-regulation? And is that something we need to really focus on in this field?
Before we move to peripheral, Sahil, one question to Sandeep. Sandeep, I like very much your talk because the message is not, this is not a war. This is not a stent versus DCB. Remember that. I think that one complement each other. I think that's a very strong message that you quoted in one of your slides. So when, in the modern era now, when instead of going crazy, I'm obsessed with DCB, all I want in my life is DCB, I think that this is perhaps a little bit too much. In your practice, how often do you have more like a hybrid approach? Let's say in a long lesion that you do spot stenting, or in multivessel disease, you stent some vessels, you DCB the others. What is, if you want to give an estimation of the percentage in your practice?
Thanks, Alex. I agree with you that this thing has to go, that stent everything. I say that very rarely in my practice I've seen type A lesions. These days, I don't see any type A lesions, type A or type B. It's always complex lesions like long diffuse lesions. So for me, hybrid is almost 20 to 30% of my cases are hybrid. But I put the stent left main proximal, I still believe in stents on those big vessels. And I want to avoid putting stents in the mid-distal LAD, PDA, PLV, circumflex, especially those marginal branches and ostium of the circumflex. So DCB has a role in these kind of lesions. In my practice, almost 20 to 30% of my cases are hybrid.
Any question from the audience? I see experienced physicians. Fernando Afonso is here, Manish. Very privileged, great privilege. Do you have any question, Sahil?
Any questions from the audience? Here's a question. Yeah.
Is there any way you can tell the shelf life of a drug-coated balloon compared to a drug-eluting stent? That's going to be helpful. And the second thing, now that I discharge my patients after 4 hours following multivessel intervention, are we going to revert where we have to keep the DCBs overnight?
I can answer that, yeah. So I think that's a very good point, because one of the comfort we get with the stent that we can sleep well at night because we'll not have an acute vessel closure. That is one of the questions I get asked all the time. So in my practice in Birmingham in England, we send the patients home same day. Elective patients, they go home 6 hours post-procedure. If I have any concern about the dissection or something, I admit them overnight, but almost 90% of patients go home the same day. On antiplatelets, I rely a lot on these antiplatelets, so I have a very low threshold for using ticagrelor or prasugrel. So with that, I think my acute vessel closure in the last 9 years is only one case. This was like a long time ago. It was maybe my mistake. I didn't prepare the lesion well, but almost nil acute vessel closure. So you can send them the same day. We have same day discharge all our patients.
And the other question was about shelf life, right? With the Manish, what is the shelf life in the EU for MagicTouch? So it's 2 years for coronary DCB in EU, and in the US, what's our IDE currently? 6 months, but we're expecting at least 12 months, and then probably 12 months. So one thing that I wanted to emphasize, and Aloke, maybe I can ask you first before I ask Ulf. There's been a lot of question marks about the purported tissue concentrations of drug between manufacturers. I've seen lots of hype and myths and misinformation, frankly, which as a drug delivery scientist I find vexing. But there's no ambiguity about the biological effect. If there was inadequate tissue concentration, I would submit that we would not have seen non-inferiority in binary restenosis, which is an objective measure, at 12 months. So can we now say that there's no doubt that there's therapeutic efficacious levels of sirolimus after MagicTouch DCB in the SFA compared to all-comer approved paclitaxel DCBs? That's a simple yes or no question.
Yeah, no, I would say yes, because ultimately what matters is the clinic. The animal models, the clinical data is only supportive to the clinic, and we really look to guide our success not by the animal models but by the clinic. And I think that SIRONA trial really was an impressive result for the MagicTouch balloon. I think it's very important to get that kind of data out there.
Right, so I'm emphasizing the point because I think that it's sort of, in my mind, settles the question about whether there's therapeutic drug levels from the MagicTouch DCB. There's no question in my mind that these data that Ulf just presented demonstrate that fact.
And don't forget that when we test pharmacokinetics, we use normal animals with no plaque, no stenosis, and that is just not simply the case of what's happening in humans. So there are very many limitations to the testing in animals. We can use it to guide ourselves, but ultimately we determine safety, Sahil, in the animals, and we determine efficacy in the humans.
I agree completely. So, and how many trials with the Medline solution DCB are there randomized to paclitaxel in the SFA?
How many? What was your question?
Are there any solution versus PTX DCB randomized trials?
Not so far. No.
Correct, not so far. Okay,
No.
it was a rhetorical question.
Yeah,
So, Ulf, question.
Yeah, good evening. Nice presentations. I have 2 comments. The first one, the drug-eluting balloon is bulky, and sometimes the deliverability is challenging. Hi, Alex. This is Rifat Jabara. So do not use the DCB for its mechanical properties. Use it just as a vehicle to bring the drug to the site. As it was shown in the first presentation, I agree 100%. You need to do lesion preparation 100% before bring the DCB, because sometimes you cannot insert it, it's bulky, challenging. So prepare, and you bring it to the site. Number two, I have extensive experience with the DCB. So obviously the evidence-based medicine, the drug-eluting stent is better than the DCB in de novo lesions, but practically today, you know, I learned and now I teach, I have four indications for DCB. One, distal disease, second, ISR, third, bifurcation, and four, if you have a small vessel disease. Thank you.
Thank you so much. I think the first question is like delivery. I think you're right, because DCB are almost 2 to 3 times more expensive than stents, especially where I work. So you have to ensure when you take a DCB, you have to deliver in 2 minutes. So I get a feeling when I'm delivering the normal balloon, how difficult it can be. So if I'm struggling to deliver a normal balloon, I know that DCB will struggle. So I up the game by taking a maybe supportive guide, supportive wire, buddy wire, guide liner, and I ensure that I prepare from my side that to deliver the DCB. When it comes to the DCB itself, like MagicTouch is one of the best deliverable balloons, so it delivers very well. So I don't think there'll be an issue with that. Now the second question, what you asked me was the stent. I don't know if you've seen the REC CAGE-3 trial, which was published in Lancet this year from China, showed that if you try to compare DCB in larger vessels, I think it's the wrong thing, especially in simple, non-complex, proximal LAD RCA. I think stents give a even a bare metal stent will give a good result. So I think for me, DCBs are long lesions, diffuse disease, diabetics, as you said, bifurcation. The other indication, high bleeding risk patients, because I've had patients who have cancer surgery, waiting for a colon surgery where the hemoglobin is low, they can't take DAPT. DCBs are amazing. I just give 2 weeks of DAPT and they get operated. So yes, there is a shelf for DCB in these kind of lesions, but we have to understand that we shouldn't be competing with a stent in larger vessels, because I think we'll lose and we'll have a bad outcome. I don't know whether you agree. We should close.
Yeah, I think as the hour is drawing late, we're going to have to close this session. I want to thank our sponsor, Concept Medical, for hosting us today, and we look forward to seeing you at one remaining day at TCT.
Yes.
Enjoy your evening. Thanks very much.